So, I will be talking about the blood pressure variability in the health and disease. We know blood pressure is a dynamic parameter and keeps on changing in every second or even before that, and with every pulse the pressure keeps on changing. That is why in health this variability do exist. But what happens in various disease condition, that is also very important. So, not only blood pressure, all the physiological mechanisms keep on varying with time. And this is the circadian time structure, that every physiological function has a time of the great change and keep having a particular rhythm. Every physiological mechanism has this rhythm. So, exception is not the blood pressure, heart rate, and autonomic parameters of cardiovascular system have a characteristics and reproducible circadian rhythm, and during daytime, awake time it is different, and during night time it goes down. That is the routine, and that is why those who follow this, they are called as dippers, and there may be population which do not have this nighttime dipping. They are called as non-dippers, and even the persons, some of they have the reverse dipping pattern. During daytime the pressure is more, and during pressure is less, and during night time it is more. So these all patterns which are non-dipping pattern, reverse dipping pattern, or less dipping pattern, or more dipping pattern, are having the different type of comorbidities, and they have a different, the extreme dippers do exist. So blood pressure variability, if we talk about the mechanisms are related to physiological characteristics of the cardiovascular system, and they can vary according to the various mechanisms, and the variability and the clinical relevance is well proven. We know the relative risk reduction of fatal events and combination fatal and non-fatal events in patients on active antihypertensive treatment versus placebo or no treatment, because they do decrease the variability. That is why we have all these mechanisms are there. With an individual, blood pressure variability do exist, and it differs from one patient to another patient. Not only that, blood pressure variability is a complex phenomena which is occurring because of different mechanisms involved, and that do change with the variability, whether we are talking about the acute variability or the chronic variability, or we talking about the minute-to-minute variability or day-to-day variability. So subtypes of variability can be there: short-term variability within 24 hours, and we can further divide it very short-term beat-to-beat variability, and within 24-hour period minute-to-minute variability, hour-to-hour variability, or day-to-day variability. And we can have long-term variability, day-to-day, visit-to-visit. Every visit of the patient to clinic, we have a different blood pressure. That variability do exist. And in the countries like India, tropical countries like India, where the seasons are varying, seasonal variability do exist. In my country, especially during summertime, blood pressure goes down, and during winter it rises. So that do exist in the countries where the weather keeps on changing. So short-term variability can be beat-to-beat, and beat-to-beat variability is basically because of changing in the baroreceptor activity, and because of even respiration there is changes there, and during sleep, and the chemoreceptors may be responsible for that. And we talk about the mechanism, the central and the reflex autonomic modulation are basically responsible for this short-term variability, and we know that these mechanisms will keep on changing from person to person. When we talk about long-term variability, that is day-to-day or visit-to-visit variability, or even seasonal variability, then the mechanisms can be not so well understood, and again a lot of factors are playing a role, and that do depends on arterial stiffness, or the poor blood pressure control, or even the inconsistent office readings. So these factors do operate when we talk about long-term variability. The various methods of blood pressure measurements can also be operative. And the blood pressure variability is a known and natural characteristics of the blood pressure and is secondary to mechanisms of varied nature and divided into short-term and long-term, which we have seen, and different prognostic impacts of nocturnal blood pressure fall and short-term blood pressure variability has been seen, and been seen that when we have this type of variability, that during night time blood pressure goes down, which is said to be protective, and when it does not happen, then it is probably damaging for the cardiovascular system. So even the short-term variability, if we talk about the impact of nocturnal blood pressure fall and short-term variability, again this variability during night time, if it is going down, is protective, and it does not go down, then it becomes damaging. Same thing is happening when we talk about the overall variability, that if the variability is too much, then again it can be damaging. How it can be assessed? We have different methods to assess this, and indices are of the day to night blood pressure change and the residual blood pressure variability, trough and peak ratio. This is very, very important, and night to day ratio is again very important. And we know that at present we are more talking about nocturnal hypertension rather than the daytime hypertension, because nocturnal hypertension has been found to be more dangerous rather than, and has been more appropriate with the risk factors, are having more risk of developing cardiovascular disease. So the continuous beat-to-beat blood pressure recording can be done by NIBP, or we can have repeated office blood pressure measurements, or we can have 24-hour ambulatory monitoring, or even home monitoring can be done, and visit to visit standard deviation and other factors can be seen by that, and we can find out them. Then the residual blood pressure variability, fast fluctuation that remain after exclusion of the slower the component, the 24-hour profile through the spectral analysis we can find out, and day to day by the dipping status which I was talking about, and night to day by the morning surge. So these are the factors which we can find out, and we can have the comment on the blood pressure variability by knowing them. Beat-to-beat variability and day-to-night variability, again on the basis of that we can find out whether the population we are talking about is dipper, non-dipper, or reverse dipping pattern, or the excessive dippers. And as I mentioned, that those who are non-dippers are having a reverse dipping pattern, or the excessive dippers, they have more risk in comparison to those who are having dippers. And this has been seen more in the black population and also in the Asian population. Night to day variations are again important, and here we can measure the morning surge, which is very important, which is a dual, you can say that dual the sword, which has the two mechanisms, and physiologically the morning surge is important, but when it becomes more, then definitely it is a concern. Nocturnal dipping status is very important, and mechanisms can be the persistence of sympathetic drive at night, which does not allow blood pressure to fall, and that because of that the nocturnal dipping pattern is not there. And reducing the sensibility of the baroreceptors at night and volume overload in specific conditions can also be important, and autonomic dysfunctions like in type 2 diabetes or diabetic autonomic neuropathy again can be important for that. So nocturnal dipping status and non-dipping status is associated with cardiovascular risk, and nocturnal BP independency predicts outcome. The extreme dipping is associated with higher risk for cerebral and retinal ischemia. That is again a risk factor. That is why the extreme dipping pattern is not good. But chemotherapy do have some impact on the dipping pattern, which has been seen, and even this has been used, ABPM has been used to predict the chemotherapy-induced changes in the patients of cancer. Morning surge, which is a dual-edged sword, I mentioned that, and usually assessed during the ABPM, and exaggerated surge is associated with more target organ damage, and the leading to increased risk of cardiovascular events or death. So the excessive surge is not good, but physiologically surge is important and is always there, and is a physiological mechanism. So on the basis of that, we can find out the changing in blood pressure which is occurring, relating from the evening blood pressure to lowest BP during night time, and the pre-awake rise in blood pressure, and then the morning surge. These changes can occur in the population. When they are at extreme, they are having increased risk. Clinical relevance of 24-hour blood pressure variability has been well studied, and we have different studies starting from 1987 to the present era. We have a lot of studies have been done, and designs have been the cross-sectional to longitudinal one, and then all of them have the endpoints of target organ damage, and they have shown that 24-hour blood pressure variability has a definite relationship with the target organ damage. The relationship between 24-hour BP variability and organ damage in hypertension has been well studied, and by using 24-hour mean, we have seen that this is having a state relationship. Relation between risk of stroke and morning BP surge in the Osama study has also been proved that the risk of stroke and morning BP surge has a relationship. And then the prognostic importance has again seen by long-term blood pressure variability has also been studied, and types and prognostic significance, if we talk about the very short time blood pressure variability, again is having, because of the central sympathetic drive and decreased arterial or cardiopulmonary reflex, and this is again related to ventilation as well. And when we talk about short-term variability, it is decreased arterial compliance basically, and when we talk about mid-term blood pressure variability, it is the inappropriate dosing or therapeutic changes which are occurring in the blood pressure management. And when we talk about long-term, again, it is the adherence of drugs or the measurement methods can also be having a role. So when we talk about different type of variability, we must know that what we are talking about and why they are occurring. This has been seen that when we talk about drugs which can address blood pressure variability, it has been found that amlodipine significantly reduces short-term blood pressure variability. Not only amlodipine, all the drugs have more than 24-hour profile, and they have better outcome when we talk about blood pressure variability, and they can change and they can have control this variability better. The additional studies are required to know about the average BP levels and short-term, long-term blood pressure variability, and more mechanisms can be seen. And not only that, we should know more that drug-induced reduction in blood pressure variability, whether it is beneficial or not. Very few studies are there. One study has been done by myself, and in that the pharmacological dipping has been produced, and that was able to reduce albuminuria in patients of type 2 diabetes. So in conclusions, the average BP levels one should know, and the short-term, long-term blood pressure variability, which measure blood pressure variability to choose, and relationship with physiological variables. And not only that, risk stratification is also very important. And we should have more studies to find it out. And with a drug-induced reduction in blood pressure variability accompanied by the reduction in event rate, again we should know that, and for that we require more studies to find it out. Do different drugs have different classes have different effects? Here we have some studies which say probably CCBs are better in addressing the long-term, the short-term blood pressure variability as well, and long-acting ARBs are as good as CCBs when we talk about addressing blood pressure variability. So 24-hour BP values more closely related to target organ damage, and higher 24-hour BP variability has higher CV risk. lasting CCBs seem to be a better answer, and also the ABP, the ARBs do have the same promise. This is the we are using in our laboratory. In the 7-day monitoring of ABPM is being done. By that, we have been able to find out more about the blood pressure variability for 7 days. And not only that, we were able to find the chat in these patients. If you see here, the systolic blood pressure variability and the diastolic blood pressure variability, it is more, but the heart rate variability is very less in that particular slide which I am showing. So thank you very much for giving this opportunity, and now it is open for discussion.